Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank all our eminent guest speakers from different countries, from Canada, from UK, from Ireland, from India, from Tunisia, and from Germany for being with us today. And I would like to thank our eminent panelists from Ireland, from UK, from Germany for being with us. The first session will be Hip Symposium to last about 1.5 hours. We have 8 speakers from different countries. Each talk will take about 10 minutes, and we will allow about 2 minutes for discussion after each session. Our first speaker will be Professor Walid Qishta from McMaster University, Canada. Professor Walid will speak about hip preservation. The talk of Professor Walid and the other professor from Canada will be recorded because of the time difference between Egypt and Canada. Now it's 2 a.m. in Canada, so it's very difficult to be live with us. So the talk of Professor Walid will be recorded. The talk of Professor Walid will be hip preservation.
It's my pleasure to be with you talking about the current concepts of hip preservation for the AOA 2021. Hip preservation is an evolution in conceptual understanding coupled with technical innovations has enabled the hip preservation surgeons to address complex pathomorphologies about the hip joint. Goals of hip preservation are to reduce pain, optimize function, and increase the longevity of the native hip joint. Technical aspects include isolated hip arthroscopy, open procedures, hybrid procedures that combine the advantages of arthroscopy with open surgical dislocation, pelvic and or proximal femur osteotomy, biologic treatments for cartilage restoration. The combination of pathologic hip kinematics, dysfunctional periacetabular force, coupling, and joint incongruence propagates altered joint reaction forces and potentially accelerates degenerative changes. Pathophysiology, the most common is acetabular dysplasia. And as you know, studies have linked acetabular dysplasia to premature osteoarthritis and the increased likelihood of requiring arthroplasty. Acetabular dysplasia is responsible for 20 to 50% of symptomatic hip osteoarthritis. Alteration of the proximal femur alignment, like on the left side, coxa valga, on the right side, coxa vara breve and trochanteric overgrowth after Berthi's disease, and or combination of coxa valga or caput valga in this case with acetabular dysplasia. Or femoral acetabular impingement can be from the femur head side or from the acetabular side. Joint preserving techniques includes pre-acetabular osteotomy. It is well known as Bernese or PAO organs osteotomy that includes 4 cuts around the acetabulum to achieve better coverage. Can be done isolated or combined with osteochondroplasty that can also be done arthroscopically or open. Decision whether to utilize arthrotomy or arthroscopy is as an adjunct to PAO is mainly surgeon and resource dependent. In addition, arthroscopy can confirm the suspected pattern of joint mechanics by demonstrating edge loading on articular cartilage and further help refine the necessary corrective rotation of the PAO. Femur osteotomy, that's the other side. It can include varus osteotomy or valgus osteotomy. Again, can be combined with arthroscopy. Femur lengthening techniques, it's like Mosher osteotomy. In this case, that's a Berthi's sequelae that has coxa vara, coxa breve, coxa magna, trochanteric overgrowth. In this case, we did combined arthroscopic head osteochondroplasty and labral repair combined with femur lengthening osteotomy and trochanteric transfer. cartilage restoration can also be achieved with either autograft or allograft. Surgical hip dislocation is another technique that's a bit complex and mainly done for the skiffy. And there is a lot of discussions about the range of EVN outcomes that has been reported from very low as 1 to 4% to very high to 30%. Arthroscopy is another revolution, and that achieves a lot of correction of labral fixation, osteochondroplasty, and again can be done isolated or combined with open surgery. Now the question is arthroplasty versus preservation. Hip preservation maintains the native hip, and it's better for sports activities, especially in younger patients. Although it's complex, needs long learning curve, and mostly ends in arthroplasty, so it's mostly delaying arthroplasty. How about the arthroplasty? It's less complex surgery and relieves pain immediately. The cons is the longevity of the prosthesis, although it's 20 to 30% recently, and it's not suitable for many sports activities. The poor outcomes of hip preservations are related to patient age greater than 35 years, incongruency of the hip joint, or advanced osteoarthritis. Now, I like this study that was published February 2020 about the intra and intra-observer reliability for predicting hip preservation versus hip arthroplasty, utilizing plain radiographs with comparison of surgeon specialization. One group was hip arthroscopy and another group was arthroplasty. It's interesting they found that more significant reliability towards hip arthroplasty came from hip arthroscopy surgeons. Also consider simultaneous open and arthroscopic surgery. It has better results and better outcomes and better rehab to the patients. Take-home messages: hip preservation is a valuable option when indicated. Poor outcomes with older age, more than 35, osteoarthritis, and incongruency. Combined osteotomy and arthroscopy has better outcomes. Thank you very much.
Thank you so much, Professor Walid, for being with us today. Unfortunately, the presentation of Professor Walid is recorded because of the time difference between Egypt and Canada. But if we have our eminent panelist, Professor Mohamed Imam from East London University, Professor Ayman Suriel from Codwalder, UK, Professor Ibrahim Kamar from Sligo University Hospital, Ireland, Dr. Rami Sharif from Frimley Park Hospital, and Dr. Rami Zahar from Munich, Germany. If we have our panelists with us, please, if you have any comment on the talk of Professor Walid Kashta. Okay, we will move to the next speaker. Our next speaker will be my dear professor and my dear friend, Professor Sofiane Khalal from Tunis. You are very welcome, Professor Sofiane. Professor Sofiane will speak about fractured femoral neck in young adults. Thank you so much, Professor Sofiane, for being with us today, sir. Thank you.
Thank you very much. Thank you very much. Just waiting for sharing the Do you see the presentation?
Not yet, sir.
Not yet, sir. Okay, perfect. Why I could share for me, it's okay?
No, it's not obvious here, sir.
Desktop. Yes. Yes.
Professor Sofiane is one of the eminent stars of AO in Tunisia and all over the world.
Thank you very much. Okay. Okay. Do you see it now?
No, sir. Yes. I think it will start. No, not yet. Not yet, sir.
Okay. I don't understand why he wouldn't like to connect it. Okay.
Do
you see? Because I click on Zoom share. It's done for me, it's done. I don't understand why.
Just share screen, sir.
Yeah, I put share screen. Is it?
No, it's not obvious here.
I put share screen and it doesn't share. I don't know why. Desktop.
Try again, please.
Yes. There is problem. This is problem of iOS when they for security problem. I don't know why is. I'm sorry about that, but I think there is problem with sharing the screen. We can go to the next, and I will be back within 10 minutes.
We will move to the next speaker, and we will be with you again, sir. Our next speaker will be Professor Ulrich Lenze from Technical University of Munich. Professor Lenze will speak about the management of tumors around the hip. Professor Lenze, you are with us?
Yes, I'm here. Hello. Thank you for the invitation. It's a great honor. Thank you.
And thank you for support.
Will you show the video?
J'ai un problème pour partager l'écran.
We are waiting for sharing your screen, Professor Lenze.
Okay, will you show the video I've sent through to you?
You can share the video. Professor Lenze will be with us.
Will you show the video I've sent? Good day, everyone, and Ventily greetings from Munich, Germany. First of all, I'd like to thank my friend, Professor Ashhab, for the invitation, which really means a great honor to me. Thank you very much. Today, I'm going to talk about management of bone tumors around the hip. As you know, primary bone tumors show a certain distribution pattern with a peak incidence during the first 2 decades of life. So the older the patient, the more likely is a metastasis, or with other words, a bony lesion in a patient older than 65 years of age is a metastasis until proven otherwise. Primary bone tumors most frequently affect the region around the knee joint in children and the knee and the hand in adults. The proximal femur is affected in about 10% of cases, both in children and adults respectively. One has to keep in mind, though, that also about 12% of secondary bone tumors, bone metastases, arise around the hip. In a survey of the Musculoskeletal Tumor Center in Munich, we evaluated all primary bone tumors which are arising at the proximal femur, which were treated during the last 5 years. So about 70% of all cases were benign tumors, and only 30% were malignant primary bone tumors. Most frequently seen entities were chondrosarcomas, fibrous dysplasia, which is in fact a tumor-like lesion, osteochondroma, enchondroma, osteosarcoma, and Ewing's sarcoma, to name only a few. As tumor surgeons, we have to resect the tumor, but on the other hand, we have to reconstruct the emerging defect too, which can be cavitary, intercalary, or osteoarticular. In benign lesions, we most frequently deal with cavitary defects or incomplete intercalary defects. in malignant tumors with intercalary or osteoarticular defects. And there is a third group of tumors, the so-called locally aggressive or semi-malignant tumors, which can be well circumscribed to massively locally aggressive and cause even osteoarticular defects. Even benign tumors can be very, very tricky to treat at the proximal femur and the hip. And here an example, this is an 18-year-old female patient with a chondroblastoma to the proximal femur. So the challenge in this case is how to resect the tumor. It's really close to the joint, to the articular cartilage, and actually it's tiny. So during my time in Switzerland, Professor Andy Krieg and myself developed a minimally invasive technique using tubes. These tubes are usually used for intramedullary leg lengthening. And via a K-wire and a cone, you're inserting a tube into the bone, which serves as a working channel. In a second step, you put a bone punch in for punching out the bony access path, which can be reused after tumor resection for closing. You can then resect the tumor using whichever instrument you like reamers, curettes, whatever. Everything is preserved via the working channel. And in the last step after tumor resection, you can fill it up using pessels. And this is an X-ray 2 months postoperatively. The patient was very happy and pain-free at the time. So here is a second example of a benign lesion, 30-year-old female patient with a fibrous dysplasia to the proximal femur. And this fibrous dysplasia is surrounded by regressive cysts. And you can imagine that there is a high risk for a pathological fracture. So you have to resect it. The challenge in this case is how to stabilize the femur after resection, because the fibrous dysplasia and also the cyst are thinning out the lateral cortex of the greater trochanter, making the use of a dynamic hip screw or a short proximal femur nail suboptimal. So in these cases, we recommend the use of long intramedullary nails with a long diaphyseal fixation distance. This makes a really, really stable construct, and we haven't observed pathological fractures in these tumors after resection. In malignant tumors, we have to differentiate primary bone tumors from secondary bone tumors. So the survival rate in primary bone tumors like the osteosarcoma or Ewing sarcoma can be as high as 70%. And so our aim in these patients is a long-lasting reconstruction. In contrast, in secondary bone tumors or patients with secondary bone tumors, our aim is to bring them back on their feet as soon as possible and give them a good function. So here, one example for a secondary bone tumor, a 56-year-old female patient with metastasized breast cancer and a metastasis to the proximal femur on the right-hand side. You can see this big osteolysis and the high risk for a pathological fracture. So in these cases, we do a tumor resection and put a cemented endoprosthesis in, plus or minus postoperative irradiation. To our opinion, the advantage of this procedure is they can return to full weight bearing quite early, and you have to keep in mind that a high percentage of these patients dies within 12 months. The function is relatively predictable, it's quite reliable, and we have a wide range of implants, even custom-made and modular prostheses available to deal with these conditions. It is a different story in primary malignant bone tumors, though, as already mentioned. So we need a long-lasting solution, and in theory, we have two options: a tumor endoprosthesis or a biological reconstruction. In situations like in this patient with this 35 years old patient with a chondrosarcoma to the proximal femur, where the epiphysis and also the metaphysis are affected, we think that a biological reconstruction doesn't make any sense. So in these cases, we use tumor endoprosthesis, a proximal femur replacement. But you have to keep in mind that in tumor endoprosthesis, you have a lifelong risk for complications. And Henderson and colleagues classified these complications in mechanical and non-mechanical complications. Peter Ruggeri and colleagues did a survey on complications in nearly 300 tumor endoprostheses and found the failure rate to be as high as 28% after a median of 1.7 years. So that's why we have the opinion that you should do biological reconstructions whenever possible. And we have plenty of options. You can use autografts like a vascularized fibula graft, allografts, extracorporeal irradiation, bone transport, Mascali technique. It really depends on the preference of the surgeon or the tumor center. Here an example. This is a 12 years old girl with a Ewing sarcoma to the proximal femur. As you can see, the epiphysis and also the metaphysis are tumor-free. So I think this is a perfect candidate for biological reconstruction. And in this case, we did a wide tumor resection and an acute intraoperative shortening and a plate fixation. So this really worked pretty well. The patient achieved good function after the procedure, and she is now due for the second step of reconstruction, a retrograde femoral lengthening for limb length equalization. Here, one last example. I think this is really an extraordinary case. 6 years old boy with a massive Ewing sarcoma to the proximal femur, reaching all the way up to the femoral neck. Well, in this case, we did also a wide resection, bridging the bony defect with a vascularized fibula graft and a plate fixation. And you can see just a bit, or the epiphysis and a bit of the metaphysis were preserved. And this is the result after metal removal 2 years postoperatively. And I think it's really a great result. So to sum it up, about 10% of primary bone tumors arise around the hip. The management of these tumors and in this area can be very challenging due to anatomical preconditions. Our approach is in secondary bone tumors, we do cemented endoprosthesis and/or irradiation. In primary malignant bone tumors, we try to do biological reconstructions whenever possible, but endoprosthetic reconstructions can be a very good option, especially if the epiphysis and/or metaphysis is affected. Thank you very much. Thanks.
Thank you so much, Professor Lenza, for being with us today. My friend, your participation is a great honor for me. Professor Lenza, of course, is one of the eminent stars of orthopedic oncology in Munich and all over Germany. We can allow 2 questions to Professor Lenza if we have questions, because we have to stick to the time. We have to stick to the time. Any questions to Professor Lenza?
Yes.
Okay. Professor Ashhab, there is just a question, technical question about the.
Dr. Brahim, you are very welcome, Dr. Brahim.
So thank you, sir. First of all, thank you, Professor Ulrich, for this nice presentation. Just, I want to ask about the role of allograft prosthetic composite in your cases. Would you like to use it, or don't prefer to use this type of prosthesis?
Well, we rarely use allografts. We've done it in the past, but we've had some complications, especially fractures and infections. So we try to use vascularized autografts whenever possible. or endoprosthesis. I think even tumor prosthesis work very well in these cases. Where we use allograft and prosthesis composites is at the shoulder, especially when doing shoulder replacements after tumor resection. This can be a really a nice option for reconstruction of the rotator cuff, but we use it rarely, to be honest.
Okay, thank you, sir. Thank you.
Okay, any other questions? Thank you so much, Dr. Lenza. Yeah, Dr. Rami, you have a question?
Yeah, it's just one question about intraoperative and preoperative strategies to make a decision between joint preservation or joint sacrificing. So what are your strategies when you face a pre-articular malignant tumor, preoperative strategies and intraoperative strategies?
Actually, we do our planning pre-operatively. So we do another MRI scan 2 weeks before the operation. In children, if the epiphysis is affected, then you usually can't preserve the joint. It's too close, the anatomical preconditions are too small, and in many cases you can't preserve the joint. In older kids, if there is enough bone stock, you could, like with an A-frame. We are about to publish this technique with a folded vascularized fibula graft, as, for example, at the distal femur. But in most of the cases, if the epiphysis is affected, you can't preserve the joint. And of course, if there is tumor tissue within the joint, then you have to do a closed joint reduction and put a prosthesis in.
Thank you very much.
Thank you so much, Dr. Lenza, for being with us today. Your participation.
It's my pleasure. Thank you very much.
Thank you so much. Professor Sufyan, the technical problem is solved?
Yes, I hope so. I hope so. Okay. You see my question? You see my screen now? For me, it's okay now.
No, not yet, sir.
Just a second, it's coming.
I can see
Sufyan's
presentation from here.
Yeah.
Okay, you see it, all right?
Yes,
That's okay?
We are able to see your screen.
For me, it's okay.
Yeah, we are able to see your screen.
It's done? It's good?
Yes, sir.
Okay, perfect. Thank you very much. Thank you to Dr. Professor Ashhab for the invitation. And it's a great honor for me to share our thoughts about femoral neck fracture with our colleagues and the residents of Banha University. Thank you very much. It's a challenging, it's always a subject of debate, the femoral neck fractures. Femoral neck fractures in young adults, but there are some points which I'll always discuss it. How urgent are femoral neck fractures in young patients? Is it the same thing in the elderly or not? Is there a difference in outcomes between open and closed reduction? We will answer to this question. We will describe the pros and cons of different cervical approaches and what is the best implant for femoral neck fixation. Are complications common after this injury? I think it's the same thing for the elderly, and some specificities for young patients. You have just to remind that most of the femoral neck fractures are either high energy fracture, less than 50 years with normal bone physiology. They're affected extremely short and external rotation, and polytrauma, we should always consider femoral neck fractures in young adults when they have in conditions of polytrauma. The imaging AP and lateral, they give you the diagnostic. It's very easy. It is usually very easy in displaced fracture. You need only AP and lateral hip to see your fracture. And this is the lateral view to show the displacement. The question is, do we need CT scan? Yes, may help to establish diagnostic in rare circumstances, mainly in stress fracture or in suspected non-displaced fractures. and aid in fracture characterization and treatment decision, mainly in vertical fractures and when you have posterior communication. We should be aware that in Garden 3, we will see that later. In Garden 3, sometimes you see that displacement is not very important, but there is a big posterior comminution, and which affect the vascularity of the femoral head. The most two classification, what are adapted, remains the same, which is Garden and Powell's classification that give you the widest description in the literature that we have. The Garden 1 and complete valgus impacted. Garden 2 is complete but not displaced. And 3 is partially displaced, which mostly in Vara. And incomplete fully displaced, it means there is disimpaction between the neck and the head. Second point, which is very important in the classification, is the Powell's classification, which gives you the idea about how vertical the fracture is. Most, when you go to the vertical fracture, the risk of displacement is very important, and the shearing forces are very important, that we need to adapt our strategy technique or to add some surgery trips. Traction is contraindicated with the risk of tamponade to high pressure. No traction for young patients. It's a surgical urgency, but not an emergency. Accuracy of reduction is more important than time of surgery. It is very important to have very, very good reduction, atomic reduction. Earlier is the better, usually within 24 hours maximum. Personality of the fracture and patient conditions are elements that to take in account, and mainly for the patient. What about definitive management? It should be ORIF, mainly in most cases. Sliding hip screw, which has much more, the most common type of ORIF. Anti-rotation screw, if there is risk of rotation displacement. Conchal screw in undisplaced fracture, blade plate or modern plate system, which are not really very largely adapted for many reasons. There are some failures in the type of screws and plate of the latest ones of Synthes. And there is object of debate between open and closed reduction, and total hip replacement may remain the last possibility in very displaced and comminuted fracture. If we open, what approach? Anterior approach to the hip, it is the most adapted, the most anatomic. The direct anterior is the most anatomic in supine position. Otherwise, we can go for anterolateral approach to hip Weston Jones, or lateral hard hinge, or lateral positions. Open versus closed reduction. Recent data to favor to closed reduction. A trend 10 years ago was to open reduction, but now we are mostly for closed reduction, to try to obtain closed reduction. But in very displaced fracture that we cannot reduce, sometimes we are obliged to go for open reduction. As we said, accuracy of the reduction is the most important point. You have some reduction techniques and tips. Reduction technique with pointed reduction clamp, joysticks, key wires, and I do insist about the X-ray that you see on the right side. That there is a small lever that you see in the fracture. There is a lever on the fracture just to help you to reduce and to bring the cortices just one in front of the others to avoid the sliding of the femoral head. The reduction technique, then you use key wires, and you have on the right side the reduction collinear clamp, which is very useful. Unfortunately, it is not very common use because it's a very expensive one, and the joystick in the bottom. And we added on the case, which is on the lateral part, where we see the indication of adding a plate to the reduction and the fixation of the femoral head. What about capsulotomy? It reduced intracapsular pressure from hematoma. But it is clinically relevant? It decreased capsular pressure, not associated with AVN, but it seems that we have to confirm that with more studies. Fixation technique, sliding hip screw, anti-rotation. When you have a risk of rotation, you can add a second screw. But the conchalar screw fixation concept, it is a triangular concept. The inferior screw should be 3 millimeters from the calcar and 3 millimeters from the cortex anterior and posterior. There are some studies that prove that there is an aid when you have a little bit convergent screw in the proximal part and not strictly parallel, like you see them here, and you need them more closer. There is an important point here that you shouldn't go lower than the smaller trochanter. Don't go lower than the smaller trochanter, and you can get it 3 millimeters from the cortex calcar and 3 millimeters of the cortex on the posterior. It was already described since 1998. Stress fracture in young adults are really not very rare, insidious onset of pain, and mainly for runners, and mainly women. Femoral neck. This is an example of displaced femoral neck, stress reaction microscopic fracture. The diagnostic, sometimes we need an MRI if there is suspicion. This is the fracture, and this is the reduction with screws going just 3 millimeters from the part of the head. There is a new trend now is to use a medial buttressing plate for displaced and stable fracture. This is the effect of the calcar femoral neck plating on vascularity of femoral head. We proved in 2091 that there is no risk calcar femoral neck plating at 6 a.m. and the clock position of the clock face is at minimal decrease of femoral head and neck vascularity, and therefore it may be considered as an adjunct to laterally based fixation for reduction and fixation of femoral neck fracture, especially in younger patients. We remain that the conservative treatment remain the gold standard for young patients. This is the photo of Jeremy. This is the plate at 6 o'clock. You see the aspect, but we have to need after that a sliding screw plate. This is, but sometimes you can miss femoral neck fracture associated mainly in polytrauma. You have femoral fracture and femoral neck fracture. It is between 5 to 10% of femoral shaft fractures are associated with femoral neck fracture. And mostly the fracture is vertical, is Powell 3, which is the most frequent after the fracture dislocation of the hip. And when the patient goes to the CT scan or MRI, you can see the fracture when it is missed. This is another case. You see that there is a fracture of the femur, but you see how the fracture is really very vertical. It is among the worst fracture that you can see on the femoral fracture, since it is inverted fracture and Powell's 3. This is the reduction, the fixation. We have done a retrograde nail and then screwing of the head. The patient was really very fortunate in this case because most of these fractures, which are really very vertical, are very difficult to have this healing. This is another case, femoral fracture, isolated femoral fracture. But this is very typical case when they put this is a pre-op CT scan. There is no fracture on the femoral neck, but when they put the nail, distal nail, I think the forces were, the hammer was very important and they fractured the femoral neck, and we were obliged, you see here, that there is a secondary fracture. And be aware that you can risk a femoral neck fracture if you go very hard with your hammer with the retrograde nail. In unstable fractures, and mainly in Powell 3, if you have difficulty to reduce the fracture and to have stability with the fracture, you can convert the vertical shear forces into compressive forces with proximal femoral osteotomy. Two main complications that you can have after femoral neck fracture: osteonecrosis of the femoral head. It should be taken to reduce the risk of femoral head necrosis. When you have poor reductions, Powell 3 fractures, alcoholic patients, smoking, failure of hardware, and high BMI, since the shear forces with the heavy patient is very important. Second risk is non-union. The incidence of non-union after femoral neck fracture has been reported between 10 to 23%. Initial fracture displacement quality of reduction, increasing the patient age correlates with higher risk of non-union. It is mainly Powell 3 and reported that 8%, and there is risk of non-union. And if you have non-union, I have two options. If the femoral head is viable, you can go for high femoral osteotomy. If the femoral head is not viable, you have to go for an arthroplasty. The arthroplasty remains the last chance for these patients to consider in patient advanced age, non-retractable, very extensive comminuted fracture or subcapital fracture when the reduction is very difficult, and it's very difficult to non-obtain vitality of the femoral head. You have to consider total hip arthroplasty. Then femoral neck fracture in young adults, the goal is conservative treatment. Choice of approach based on fracture pattern and location. Anatomic reduction is critical, is the most important element in the follow-up of this patient. Fix ideally within the first 24 hours. Open versus closed reduction, less important than accuracy of reduction. But sometimes to have an accuracy of reduction, you have to open. If you open, please go for the anterior mini-invasive and put a plate at 6 a.m. Compression screws are used mainly for Garden 1 and Garden 2 fractures. Sliding screws, Conchelle screws, conflicting evidence, there is or outcomes, more failure are different. Adding plate in a high-risk displacement with anterior approach. Attention to high-risk level of sport and the risk of stress fracture in femoral neck fracture in young adults. Particularly attention to polytrauma with associated fracture, mainly with femoral fracture. As we said, between 5 to 10% are associated with femoral neck fracture, and the counsel patient early regarding significant risks of complication and reoperation. Thank you very much.
Thank you so much, Professor Sofyan Kalali, the head of AO chapter in Tunisia, for being with us today in this marvelous presentation. We can allow 2 questions to Professor Sofyan. If we have any questions to Professor Sofyan. Our panelists, we have any questions to Professor Sofyan? Okay, thank you so much.
Please.
Thank you.
Yes, please.
Regarding, thank you for the excellent presentation and the all the information. Just a question about the concomitant shaft and neck of femur fracture. Would you normally do sort of an overlap between your DHS plate and the nail? Thank you.
No overlap between the nail and not to create a free zone. I don't put an overlap. We try to reduce and separately from the toes. In some rare case, we use long gamma nail, long nail, and we try to reduce in the same time both of them. But it's very difficult in such case.
All right, thank you.
Thank you.
Thank you so much. Thank you so much, Professor.
Thank you. Thank you. Bye-bye.
Thank you. Now we will move to the next speaker. Our next speaker will be Dr. James Knotts from Frimley Park Hospital, UK. Dr. Knotts will speak about principles of hip arthroscopy.
Good morning, everybody.
You are very welcome, sir.
Thank you very much for having me. I'll just get my share screen up. So, right, I'm hoping that you can all see a lecture.
Yes.
Wonderful. Okay, so 10 minutes, off we go. So a very common topic from the previous speaker. Hip arthroscopy, rather less so, a bit more of a rare procedure. So I'm joining you from Frimley Park Hospital. Here we have a hip fellowship in young adult hip and hip arthroscopy. It's not that common. There's a few centres in the UK that specialise it, and there's even fewer that have hip fellowships. So if any of you are interested, please contact us at the team here. We'll talk through briefly, because it will be a warm-up. There's talk after me on some more finer elements of hip arthroscopy. So I will give you the overview about patient selection, workup, and theatre challenges. Why is it important? Well, although not as common as a femoral neck fracture, it is a procedure that has vastly increased in number over the past 15 to 20 years. Our own NHS, the National Health Service in the UK, has seen an increase of 700%. And that's a taxpayer-funded procedure, so it has to be proven, and we have to keep the evidence effective. In North America, it's even higher, and the projected increase up to 2023 on a recent paper was upwards of 1,300%. So why is it that the specialty of orthopaedics has been around for so long, but hip arthroscopy is relatively new and upcoming? Well, it's quite simple, really. The effect of technology, the effect of invention. And the two in particular here are the use of the arthroscope and the equipment required to provide arthroscopic equipment that works well in a confined space. And the second is that of imaging and the effect that the MRA, so the arthrogram, the magnetic resonance arthrogram, and the use of gadolinium scans has given us a much better idea of the pathophysiology and the anatomy of what's going on with young hips and young adults, in particular around the labrum. And as we've got a greater understanding of the labrum and its pathology, we've also developed technology to help us address that. So that's the overview. That's why hip arthroscopy is a major deal now. So for what is it that we're using it for? Well, the main ones are femoroacetabular impingement, and that in itself is a talk on its own merit. Labral tears, and we'll talk about the association between the two. There's other reasons that we can use hip arthroscopy, including extra-articular impingement, the finding of loose bodies, and in some centres they are considering it for the initial washout of septic arthritis, but I would be cautious, and we certainly don't use that in our centre. So who are we, and what patients are we dealing with? Well, classically, young adults who are highly active, high demand, and high expectations. So this poses a problem because our treatments are difficult and our patients are extremely active and they demand the very, very best. These patients tend to be sportsmen and women. They may do repetitive exercises such as kicking sports. They may be low squatters, rowers, and they get pain in their thigh, they get pain to their symphysis pubis, and they get pain even if they're male round to their ipsilateral testicle. So these patients are sent into our centre from other centres in the area to see our young adult specialists. A little bit about the labral tear and the femoral acetabular impingement. What comes first, the chicken or the egg? And it's an expression we use because you can have a labral tear in its own merit. You can have a labral tear on its own. But can you really have femoral acetabular impingement without a labral tear? And therefore, why is that important? Well, because if we're going to address and surgically manage their labral tear, and we do not manage their femoral acetabular impingement, it is rather much like repairing a meniscus and not doing the ACL reconstruction. You're dooming your repair to failure. So it's important that these two are held hand in hand and addressed together. So what types of femoral acetabular impingement are there? Well, this is textbook stuff, but it's important. And there you have the cam and the pincer. The pincer being that of the acetabular rim and the cam being that of the femoral neck. And once again, treating one without the other may be foolhardy, and so it's important to address them both if needed. So we need to work out exactly which patient is the right patient. And there is evidence and research based on which are the most sensitive tests to perform in clinic. And in particular, the FADER test. So this is the flexion, adduction, internal rotation of the patient's affected limb. That will most likely get your anterosuperior labral pathology shouting at you. There's other tests such as the external rotation modification, the Faber test, and that may look at posterior impingement. We talk about the C sign. And so this gentleman in the picture here, he's holding his hip in a very characteristic method, and it's very sensitive. Patients who come in, athletes, and hold their hand across their hip, say, this is where it hurts, doc, they do tend to have labral pathology, log rolls, and then hip scores. And hip scores are important because we will talk about the research coming forward and the registry data. So initial imaging. Now, this is the crossover sign, okay? And this is essentially a focal retroversion sign of the acetabulum. And if positive, it's highly likely that they'll have a pincer morphology. Okay? This is the done view, the lateral view, and here we can look for the cam. And we can measure the cam based on their alpha angle. And the alpha angle in our practice, we look at anything over 55 degrees as abnormal. And you can see here on that cartoon how that's calculated. Onto imaging. So here's the MRA, and here you can focally see the labrum. You can look for cystic change on the femoral neck, and these are all important features and also can be prognostic as well. The patients who have the cysts may well not do as well as those who don't. may show advanced injury. There's also a vogue now to perform CT scans that then computer modeling can look at the on and off track injuries. So much like the shoulder, where we talk about Hill-Sachs lesions, you can start to look at the femoral neck in that manner as well and try to work out through computer analysis where impingement is going to occur. Our patients head off for an injection. That's diagnostic and very important. They have to get better from their injection for us to warrant invasive surgical intervention. So theatre setup. Okay, those of you who have or haven't seen how we set up, it's very important that we use a traction table. And the traction tables have moved on now from the trauma traction table to dedicated hip arthroscopy traction tables. And our centre would only use the dedicated traction table. The anaesthetist must get the muscle relaxant on board. We use specialist boots, make sure the patient doesn't slip out. And that is a very, very well padded perineal post. That is absolutely important so you don't get a peroneal injury. And this is what it looks like when we're all set up. So it's a bit chaotic. This is a distraction vector, and this is an important concept. We make sure that we're subluxing the hip in the direction of the femoral neck. So we're not pinching down on the inferior surface of the head. So adduction of the patient's operative leg is important to do that. The portals, as described in the literature, the ones that we use are the anterolateral portal and then the accessory anterior portal. The posterior lateral portal, mostly written up by Bird in around 2006, used less often. Watch out for the anterior portal on the lateral femoral cutaneous nerve. Traction time goes on. Okay, have about an hour, 2 hours maximum on traction. And the first thing we do is perform an air arthrogram or a saline arthrogram, and then we use nitinol wires to pass into the fossa. It's imperative at this stage that you don't pass through the labrum. If you do, you need to address that. So you must pass your introducers, your trocars, below the level of the labrum. Otherwise, you're going to cause iatrogenic injury or actually make your procedure very difficult. The equipment that we use, so we're using a 4mm scope with a 70-degree angle. That does have a blind spot, but it's the most useful for us. We use the use of passing wires, switching sticks, and here you can see the lateral gutter which is used. We use an electrocautery device called a werewolf, which is a plasma creating device, but there's other alternatives. And then the way in which we are taught or use the capsulotomy. In North America, the capsulotomy tends to be a larger knife-based instrument. Here we create a cone using the electrode diathermy, so we'd have to repair it afterwards. And here's some cartoons and images of what we're doing. So this is the acetabular rim debridement, and we're taking down that extra bone, and then we're reattaching the labrum using something like a suture anchor, which is what we use, so there's no foreign bodies should it fail. And here's some pictures of that occurring. And here's a final image here showing 3 suture anchors with the labrum reattached onto the new bed that we have created, having taken down the acetabular rim. Moving on then to the anterior accessory anterolateral portal, and this is where we can address the cam. But here we can take the traction off. So your first hour is the labrum, and the second hour may be the cam. And we talk about mowing the lawn. So in the UK, we mow our lawns a lot, and we love our mowers. And so we take the burr and we mow a lawn. And that's important that you start in one place, pick your depth, and work your way slowly backwards. So moving finally on to the rehab for our patients, and we get them out the same day. It's day case surgery in the UK. We tell them to avoid heavy lifting, deep squatting, and we see them again in approximately 8 weeks, and when they can start their more aggressive physio rehab, especially if there's a labral repair, we want to protect that. Lots of research in the past 10 years and more about hip arthroscopy, and it is imperative that we as a community continue to research the work that we're doing, otherwise we will lose funding for it. This is the Fashion trial in the UK, done about 4 years ago now, and it showed that there was a clinically significant improvement with hip arthroscopy versus physiotherapy. But they did it again just this year in Australia, and they couldn't reproduce those results, showing that physiotherapy and arthroscopy were similar. So it is important that we continue to ask the questions. And finally, we record all our information onto a non-arthroplasty hip registry. And I know you guys are going to have a registry day to talk about the UK version of hip arthroscopy, of hip replacement registry data, but we do have a non-arthroplasty registry. So thank you, folks. That's 11 minutes. I hope you don't mind that I've gone over a minute. Any questions?
Thank you so much, Dr. James Knotts from Frimley Park Hospital. And thank you for my dear friend, Dr. Rami Sharif, for being the coordinator of your presentation, sir.
Yeah,
we have Dr. Ayman Surial with us. Dr. Ayman, you have any questions, sir? Dr. Ayman,
thank you very much, James, for a lovely presentation. I've had the fortune of doing a hip fellowship in the North as well. I trained in hip arthroscopy. I was actually one of the blinded assessors for the FATE trial, so it's lovely to see your lovely presentation. It's really amazing you're sending patients on the same day. Up north, we're still kind of keeping them overnight. Do you manage your post-operative pain any differently than what we do?
So if they have a spinal, they have a low weight spinal so that it wears off quickly, and they're first on the list. But actually, we're pushing towards general anaesthetic now, and the anaesthetist gives just high dose intraoperative analgesics, and then afterwards they go home on very little. They're seen by the physio prior to the procedure, which makes a big difference. It gets them mentally ready for it, and we counsel them in clinic that it's a day case procedure. So I think, yes, you're right. It's important that the patient's on board with this, but day case surgery does take a lot of effort.
Lovely. And regarding patients who have recurrent pain or ongoing pain, I mean, we know that at best hip arthroscopy would give somewhere 70 and 75%. I wouldn't normally raise the hopes of my patients any further to that.
Agreed.
In terms of rescanning or reoperating, what's your standard protocol, please?
So the team that I work with, reoperation is a very, very rare occurrence, and that would be an exceptional circumstance. You'd have to look to see whether a foreign body had been created or whether there's a loose body post-procedure. For us, managing patient expectations is the mainstay of our clinic. And I don't have a good answer for you with regards to that 30 or more % of patients that continue to come back with high levels of athletic pain, let's call it. So they're professional sportsmen and women who then simply might have to have a thought about what it is that they're doing to influence their pain. And we do have a lot of patients who do ultra marathons and Ironman challenges, and it's extremely popular nowadays. And that's the difficult conversation that we have to have with them. I'm sure you have the same.
Yes, and yeah, thank you for that. I think the most difficult conversation is the cutoff limit as regards BMI and activity levels, and we find it rather difficult for patients coming in having been diagnosed with a labral tear and they say want hip arthroscopy. Do you have a BMI cutoff limit?
Particularly, there isn't one overall, but we wouldn't really look at around 40 and above. It just makes it too difficult with portal access. You don't get that, all that soft tissue, as you know, you just can't get through and can't effectively do it. And the other question, of course, is if there really are that high BMI and it's not muscular BMI, it's adipose tissue, then what benefit are they going to seek from this?
Indeed. Thank you very much.
Thank you.
Thank you so much, Dr. Knotts. Thank you so much, Dr. Surial. Dr. Rami Sharif, do you have any questions, my friend?
No, everything is clear. Thank you.
Thank you so much. Thank you so
May
much.
I ask a quick question? Just one quick question.
Please.
I was wondering, what are your reservations on the use of hip arthroscopy for the initial washout in septic arthritis?
Okay, so that's a good question. It's just something that we have not adopted fully because we don't have the surgical prowess available 24 hours, 7 days a week. Simply put, the hip arthroscopists are not around that often. So therefore, we worry that if the patient is sat on a ward waiting for us to be available, they might miss the opportunity of an open washout. And that might change.
Sorry, carry on, sorry.
And that might change as the skill set improves. But ultimately, someone saying, oh, well, I can do a knee arthroscopy, I'll put a hip scope in. We worry that that might actually be more trouble than it's worth.
All right, thank you.
I have actually done a few hip arthroscopies for septic native joints, and again, it's the case of the opportunity of having somebody around on call or available who can do that. We found them for the times that we've done them, and we found them very rewarding. The main problem is sometimes you need to do a re-washout, and therefore you need your hip arthroscopist available again for the re-washout. That's the main issue, but I found them quite useful. And the few cases I managed for septic arthritis, I mean, some of them needed a second washout, but they went then to resolution.
Thanks.
Thank you so much. Thank you so much, my dear colleagues. Now we move to the next speaker. Our next eminent speaker will be Professor Femi Arini, the chair of Orthopaedic Section and Hep Arthroscopy Department in McMaster University, Canada. Professor Arini will speak about techniques of hip arthroscopy in difficult cases. The talk of Professor Arini will be recorded because of the time difference between Canada and Egypt. Please.
I'd like to thank the Egyptian Orthopaedic Association for this invitation to discuss complex injuries in the hip, focusing on the labrum. I'm Olufemi Ayeni from McMaster University, and although I'm very grateful for this virtual presentation, I truly hope to visit Egypt and my colleagues there in the future. Here are my disclosures. The labrum has an important function in the hip. It does have a suction seal mechanism to prevent cartilage consolidation. It helps enhance joint nutrition and also contributes to stability by enhancing stability through proprioception. The blood supply, to discuss some basic anatomy, is chiefly from the inferior and superior gluteal arteries that form a retinaculum around the labrum. And also the innervation is by the branches of the quadratus femoris and obturator nerve. So there are some fibers that can for sure trigger pain if there's some damage. And like the meniscus in the knee, the hip's labrum's capsular blood supply is dominant. We in orthopedics love to classify, and this is no different with the hip labral injuries. So when you have CAM or pincer type damage of the hip, the morphological appearance of the hip can trigger different types of damage. CAM type is a chondrolabral separation, and pincer type intersubstance damage. And this is the Saldes classification. However, we have MRI-based classification systems like the Cherney classification system. We have the zones of labral pathology classification, as you see, based on the region of damage. And the Mahorn group, perhaps the most academic group, thus classified based on multiple parameters, including size, tear location, and intersubstance changes. But when we see an MRI report with this arrow, we all know what this means, especially when a patient is symptomatic with hip and groin pain. This is a labral tear. So how do you fix these primarily? Well, you can fix this through a loops technique, which is passing a device around the labrum and looping around tissue, or you can use an intersubstance or base stitch technique, which is like a vertical mattress suture, depending on the labral tissue and quality. Both of these techniques work quite well and are effective in the primary and even revision settings. So what about the irreparable labrum? Well, you can resect it with selective debridement, or you can reconstruct it, and that'll be the focus of our talk today. So when you're looking at the case that you've seen and the case has failed or it's a primary case, it's good to have a conceptual framework in how you evaluate the hip, especially when you look at the imaging and the physical examination findings. So this concept, the layer-based concept, was taught to me by my mentor, Dr. Brian Kelly, in New York when I was his fellow. And it comes down to this. There are generally 4 layers in the hip. The first one being the osteochondral layer, the femur, the acetabulum, the innominate bone. And when a patient presents with pain, it's good to have a detailed understanding and assessment of what is wrong with these layers and what may be triggering a problem. Whether it's dysplasia, impingement, a combination of both, this is an important layer to understand. The next layer is the inert layer, which is the layer that covers the bones. And that's where you have your capsule, labrum, ligamentous complexes that can also trigger pain based on innervation of those structures. When you look at these, it's good to assess with advanced imaging, such as MRI, if there are problems or issues in that layer. The next layer is the contractile layer, the engine of the hip, the dynamic structures, all the musculature that cross the hip joint. Are these what's causing pain? And then finally, the neuromechanical layer, which is looking at innervation around the hip from lower extremity nerve chain to the lumbar spine, really understanding that these structures can also contribute to hip pain is important. So here is a case example. We have a 30-year-old referred for a second opinion because of bilateral hip and groin pain after open surgical hip dislocation for hip impingement. He also has associated snapping and stiffness, and after 2.5 years has had no relief. So I looked at this layer by layer. You could see that in layer 1, there is potential heterotopic ossification, residual hardware irritation, and some may say residual impingement. In layer 2, we will see in the next slides chondral damage, adhesions, and labral degeneration. In layer 3, with the snapping complaints, internal and external snapping hips, and deconditioning of the muscles. And in layer 4, incisional hypersensitivity from the lateral femoral cutaneous nerve. So really all 4 layers are impacted here. So in this case, we did a staged bilateral hip arthroscopy, revise the osteochondroplasty, resect the adhesions, lengthen the psoas tendon because of the snapping sensations, remove hardware, complete a burstectomy and labral debridement. And one hip, the left, completely improved, and the right hip was still symptomatic. So rather than give up, we go back to our framework to assess why one hip is completely pain-free and the other hip is still symptomatic. So we went on to image the hip to look at why this right hip is symptomatic. And if you look at that MRI or CT arthrogram rather, you could see in that third picture, you can see ossification of the labral tissue. The MRI was not significantly different, and a diagnosis of labral degeneration and cartilage thinning was rendered. So here we are now in the second revision, and look at the labral tissue. Very poor. Look at that bony conversion there, which is essentially ossification of the labral tissue. So this is now a labrum that's no longer functioning, not providing a suction seal, and not very viable. So layer by layer, layer 2 had a residual subspine prominence, but importantly, layer 2 rather had a significant labral failure, and layer 1 was a subspine prominence. You're watching a labral reconstruction, taking down the subspine, resecting the prominence of rim, and laying down allograft tissue to reconstruct the labrum and provide a new suction sealant for his hip. And at the completion of the labral reconstruction, which was 180 degrees from 3 to 9 o'clock, a microfracture is completed to stabilize and improve cartilage function. And he obtained complete relief from this approach. Here's another case example of a teacher who is 37, referred to me for a third opinion. You can see the labral tissue here in layer 2 is a problem. Not very viable, less than a few millimeters of good tissue, lots of fraying, lots of degeneration, and at 37 years old, not wanting to proceed with a hip replacement. We're debriding the labrum now, removing old sutures, just like the previous case, decompressing the rim, and after that is complete, deploying the allograft to help reconstruct. This example of a teacher who is 37, referred to me for a third opinion. You can see the labral tissue here in layer 2 is a problem. Not very viable, less than a few millimeters of good tissue, lots of fraying, lots of degeneration, and at 37 years old, not wanting to proceed with a hip replacement. We're debriding the labrum now, removing old sutures, just like the previous case, decompressing the rim, and after that is complete, deploying the allograft to help reconstruct.
Okay, thank you so much, Dr. Femi Arini, the chair of orthopedic in McMaster University. Professor Arini, his talk is recorded, so unfortunately, he will not be with us to answer questions. Now we will move to the next speaker. Our next speaker is my dear friend, Dr. Ayman Sorial from Codwalder, UK. Dr. Sorial will speak about a very important topic, the National Hip Registry. I think Professor Adel Al-Adawi is doing his best to make the Egyptian registry in arthroplasty. Dr. Sorial talk is recorded, but Dr. Ayman Sorial is with us live in the same time.
دكتور محمد دي البرزنتيشن اللي مش ريكوردد دي البرزنتيشن اللي من غير ريكوردنج.
Okay. Go ahead, sir. Thank you so much. Thank you.
طيب ممكن يسلو داون او يرجع من الاول؟
حضرتك تحب تعرضها لايف دكتور ايمن بيه؟ If you'd like. Start from the beginning. And Professor Ayman will do the presentation on the.
Start from the beginning ويمشي معايا معلش ابقى متشكر.
ابدأ من الأول. ابدأ البرزنتيشن بتاع دكتور أيمن بقى. دكتور أيمن هيقول التعليق. Go ahead, sir.
متشكر قوي دكتور محمد أشهب. Thank you for the kind invitation. I'm talking today about the National Joint Registry. The presentation is going too fast. هل ممكن إن هو
slow down في السلايدز.
انا هقول له لما يعني يا ريت الباك any joint registry starts with the point where the recommendation in the UK the recommendation came from Sir John Charlie in 1972 where it says serious consideration should be given to establish a central registry. Although this was considered to start in 1996, it never happened. Actually, it was the 3M capital hip problem that created public interest. It was about 4,500 of these implants implanted before the patients were recalled, and therefore there was public interest. Next slide, please.
Next slide.
So the public interest was through the Parliament, and Lord Hunt have initiated this, and it wasn't before 2003 that they actually started collecting data. And this is an evolving role. Starting the joint registry does not mean that we're going to start today, it's going to become functioning. Actually, it started with collecting what we call HES data, which is hospital episode statistics. And then it evolved to include the revision outcomes in 2008. I think the biggest leap was linking the NJR to the Department of Health patient outcome measures, and therefore it gave a real-time sense of the results of hip replacements. In 2011, they would also launch the supplier feedback, and supplier feedback was a massive step in gaining further funding for the NJR, and therefore it reduced the cost, because it costs about, we'll go through that in the next slide, but as again in 2012 there was more information about elbow and shoulder replacements. Thank you. Next slide, please.
Next slide.
The funding of the NJR came through a levy. A levy is like a quota. So basically, £25 for every cost of hip or knee replacement were imposed on the cost of the implant, paid by the hospital and collected by the manufacturer, and then handed over to the National Joint Registry. The costs have now reduced to about 15 British pounds, which is becoming more and more reasonable and affordable. And I don't think that's it much in terms of the cost of implants, because our implants do cost quite a lot. To put that into perspective, it's about 0.2% of the total cost of the surgery. Next slide, please.
Next slide.
So the kinds of reports issued by the National Joint Registry, we've got the Open Access Annual Report, which is analysis of data submitted. It profiles key trends, what kind of prostheses are the most common, activity levels, implant usage, and patient demographics. Hip replacements are listed as construct. So if they've got a company who has more than one kind of acetabular component, then it is the name of the construct rather than the name of the manufacturer. And therefore, it takes into consideration the different bearings and different femoral head sizes. And therefore, you tend to get the information which is related to the actual components used, and that allows more reflection. Again, it provides the visitors, this is public access, that allows the visitor the ability to analyze and compare data across different years. Next slide, please.
Next slide, please.
The NJR has also a surgeon and hospital profile. So this is also a public access, and therefore everyone can look at hospital and surgeon outcomes. For the hospitals, it would show the average gain in an Oxford hip or Oxford knee score, and also gives access to see the EQ5D and EQVS scores and how much gain. There also gives what we call thermometer plots, which is these green plots, and basically it gives an indication as regards how the trusts are functioning in terms of the average performance. Is it within average, above average, or below average? Next slide, please.
Next slide.
For the surgeons, there's also the secure restricted access, which is a security password protected area, and it allows the surgeons to look at their results even before public access. The results per surgeon is usually presented in what we call a funnel graph like this. So basically, what everyone wants for himself is to be within the blue dots. The red dots represents the outliers. There's normally two levels of outliers. The first stage is the stage where the surgeon will get a warning that his performance is outlier from the mainstream, and allows him to ask for peer review and improve. The second is when he's quite way off. To put that into perspective, for about 6,000 surgeons in the UK, being outlier is the unlikelihood is less. It's around within 100 or just over 100, and less for the knees as well. It also gives these thermometer plots, and it gives an indication of how well you're performing and your revision rates. Next, please.
Next slide.
So monitoring of devices, all implants are monitored on a 6-monthly basis and used in a similar outlier method. Normally, if a certain implant has twice the revision rate from its cohort, then that triggers an alert, and this is sent to the MHRA, which are Medicines and Healthcare Products Regulatory Agency. And it would get in contact. It's their responsibility to get in contact with the manufacturer to clarify what's happening. There's also what we call a level 2 alert, is when the revision rate is somewhere between 1.5 and 2 times, and therefore that warning goes to the manufacturer themselves to be able to look and audit the results. Most of larger suppliers would have a monthly download. They do have access to their own results, but not the results of their competitors. Next slide, please.
Next slide.
So the conclusions, the NJR has matured over the last 18 years. It started off with simple descriptive data and contains now high quality detailed outcome data with extremely detailed accurate information. The NJR has been able to identify implants that are performing poorly at an early stage. Similarly, in relation to surgeons and hospitals, providing regular feedback has a key in encouraging reflection and improving performance. The NJR is now integral to the joint replacement care package. Next slide, please.
Next slide.
The key points to this: developing a national joint registry starts with key figures and pioneers in the arthroplasty community. Political and legislative support representing public interest is essential. The professional association can be a primary hub. The British Orthopaedic Association is currently the hub for many of the smaller registries, like the spinal registry and the non-arthroplasty hip registry. Funding will be essentially linked and supported by the industry. Any registry will go through a process of formation, mandatory enrollment of the cases, building of the database, research, and linking to outcome statistics. It's a process. It doesn't happen overnight. Starts small and becomes more and more thorough and bigger. Next slide.
Next slide.
The next slide will be my references, and the next slide is thank you very much. Thank you for your time.
Thank you so much, my dear friend, Dr. Ayman Surial from Cadwaladr, UK. I hope very soon we will have the Egyptian Joint Registry. Thank you so much, Dr. Ayman. If we have any questions to Professor Surial. Okay, now we will move to the next speaker. The next speaker is my dear friend, Dr. Abhijit Salonik from India. Dr. Salonik is one of the eminent stars of orthopedic oncology in India. Thank you so much for joining us and for participation once again in our course in our conference, my dear friend. Thank you so much.
Yeah, good afternoon, Prof. Thank you very much for giving me an opportunity to speak in front of Egypt Orthopaedic Association.
Thank you so much, sir.
You can play my video, Prof, which I had uploaded.
Your presentation, I think, sir, is recorded. Yes, sir. Yes, sir. It's ready.
Showing key steps of proximal femur megaprosthesis. So, the 18 years boy with a lesion in proximal femur and was treated with neoadjuvant chemotherapy. The lesion is involving the femur bone, proximal part, and we had performed a radiograph of the patient. This was followed by a MRI, which is showing the extent of the lesion, and the greater trochanter area is not involved by the tumor. Following the MRI of the patient, biopsy was performed and neoadjuvant chemotherapy was given, and patient was planned for surgical treatment. So the position of the patient and draping, lateral position was given, and the incision is marked. So we have marked the greater trochanter, and I marked the biopsy scar of the patient. So this is the intraoperative video showing how the skin incision was marked. So we have marked the greater trochanter area and the biopsy scar, and lateral skin incision is taken so that we can reach the proximal femur and disarticulate the hip joint and resect the tumor with wide margins. This is how the skin incision is taken. Hemostasis is achieved and the biopsy scar is isolated. Following this, skin flaps are raised and tensor fascial lata is opened. So care must be taken that the biopsy scar is isolated so that it can be sent with the specimen, tumor specimen, for histopathological examination. And the skin flaps are raised and the tensor fascial lata is open. Following this, the posterior dissection is performed. Posterior dissection is performed to isolate and detach the abductor muscles and to isolate the sciatic nerve. Sciatic nerve is located in the posterior aspect of the hip joint area, and this is how the posterior dissection is performed. So here we are able to see the sciatic nerve and the abductors, and posteriorly the sciatic nerve needs to be isolated away from the tumor. Now we can appreciate here the sciatic nerve, and we are using the bipolar cautery so that there is minimal damage to the nerve while dissecting it. So these are the key steps of sciatic nerve dissection, how it is isolated from the tumor muscles, tumor area. Next step will be dissection of the abductor muscles. We are elevating the vastus lateralis muscles and dissecting it out. So that we can have a flap raised, which will be helpful for covering the implant. This is how the vastus lateralis muscle is elevated and dissected. And we can appreciate here the biopsy scar is still remaining with the tumor area. Greater trochanter osteotomy was performed with the power saw because it was uninvolved by the tumor as per the preoperative imaging performed on the MRI. The distal osteotomy was performed according to the margins that should be taken. Here 2 centimeter margin was taken, bone ear distal margin. And next step will be resection of the proximal femur. The muscles will be separated and dissected. And this is how it is performed with the help of electrocautery. The tumor should be resected with wide surgical margins. Next step is opening the hip joint capsule and disarticulation of the hip with resection of the tumor. This is how the tumor is removed out, and it's very well covered by soft tissue. Histopathological examination was performed, and here we can see the intramedullary extent of the tumor. This is how the sciatic nerve looks after dissection of the tumor. This is the distal end. This is the acetabular area. Here we can see the greater trochanter, which will be attached back to the prosthesis in future. And this is the joint capsule, so we will be able to close it after insertion of the prosthesis. So the implant used here are modular mega prosthesis. Here we can see different parts of the implant that are assembled according to the size of the patient. So this is after complete assembly of the implant. This is proximal femur modular mega prosthesis of titanium implant. So this is how the placement of the implant is done in the acetabular cavity. So this is a cemented implant. Cement is placed into the distal femur cavity and the implant is placed. We are checking the hip movements, flexion, extension, and rotation, and the trochanter and the abductor muscles will be attached to the implant with the help of ET bond suture and stainless steel wire. We have the attachment of the greater trochanter, abductors to the implant with ET bond sutures and stainless steel wire. So the capsule is closed and the muscles are attached to the implant. This is how the muscle closure is done after placing the implant, and 2 drains were placed. One is proximal, one is distal, that is in the line of incision. This is how the closure is done. This is the immediate post-operative radiograph of the patient, which is showing the implant, proximal femur megaprosthesis, and we can appreciate the greater trochanter is attached to the implant. This is how the patient is ambulated with walker immediately after the surgery on the next day. And this was the long-term follow-up of the patient. Here we can see the biopsy scar is healed. Patient was treated with adjuvant chemotherapy. He's able to get back on his leg without support. This was his hip flexion photo and knee flexion. So complete knee range of movement. He's able to do straight leg raising. The leg raising is possible without any support. So showing good functional outcome around the hip joint. This was his knee flexion and hip flexion. Proximal femur, the ankle movements are intact. The nerve is very well protected. And these patients get very good functional outcome after resection of the tumor. and using proximal femur megaprosthesis. Thank you very much.
Thank you so much, Dr. Salonik, for such a lovely presentation of this demanding case. Thank you so much, sir.
Thank you, sir.
If we have any questions to Dr. Salonik. Okay, now thank you so much, sir. Thank you so much.
Yeah. Thanks.
Now we will move to the next speaker. Our next speaker is an eminent speaker from UK, Professor Arshad Khalil. Professor Arshad will speak about primary hip arthroplasty. I would like to thank him so much for joining us. And I would like to thank Professor Mohamed Imam from East London University for being the coordinator of this talk. Professor Arshad is a recorded talk.
Hello, I'm going to talk about primary total hip replacement. My talk is actually made easy. And this was recognized as the operation of the century, almost a couple of decades ago. And we've now all seen how it has helped patients and improved their quality of life. So over the next 15 minutes, I wish to share my experience over 30 years of this procedure. We're going to look at the indications, some of the choices we make with our patients, the technical aims, the risks, and what I see in the near future. For me, the main indication is a painful hip. And we should consider this surgery only when the non-pharmacological and pharmacological measures have been exhausted. My second indication still remains pain, particularly when it starts to affect quality of life, such as stairs or putting shoes and socks on. My third indication is still pain, particularly when it affects sleep. There is very good evidence that this operation helps pain effectively, so much so that pain is now used for survival analysis. We should be cautious in offering this procedure if pain is not the major feature. Clearly, we should avoid when bugs may be around. This operation does not improve overall mobility, particularly when there are unforeseen neuromuscular issues. And we should also be cautious in offering this procedure to the very infirm, as the risks increase exponentially. I discussed the procedure with the patient, the choices of implant, the post-op recovery, and the material risks to the patient. In my opinion, the most important choice that we have to make is of bearing surface. The patient has come to us with worn-out articular cartilage, which we are going to replace, hopefully with something that will last a long time, recognizing that there is no man-made material that is permanent. So the choices we have are hard or soft bearing. Currently, ceramics paired with a highly cross-linked polyethylene seem to have as good wear characteristic as hard bearings without the risks. And having tried all three types of bearings, and now this is my go-to choice, even in the high demand patient. We then next need to choose our implant, of which certainly there is no shortage. So how do we go about choosing? Well, we can look at our practices or results from various units, or we can look at the ODEP rating, now going up to 15 years for implants with good data. The hemispherical cup is probably the go-to choice for primary surgery, with its ease of insertion, lower risks, and low risks of implantation and predictable results. The stems can be tapered or shape closed. And there are some guides of how to choose between them for particular patients. For me, the tapered stem is effective both in the cemented situation and even in uncemented circumstances with very good data. Next, we choose the head size. We know that a large head does improve range of movement, but there is a limit, and too large can result in instability. And over the last 3 decades, my choice is now 32, which has been for at least 20 odd years. And this becomes particularly important if the cup angle is not ideal. We need to understand the relationship for stability between head size, head offset, and cup angle. The next choice is how to fix our implant. Everything requires practice. A recent survey review by eminent hip surgeons concluded that one method of fixation is not justified in all patients. Therefore, the surgeon needs to make an appropriate choice for the individual patient. The final choice we make is that of approach. Currently, these 3 approaches are the most common. And having tried all 3, my approach is the modified lateral, the London Hospital approach. More important is that about approaches that we need to understand it should offer sufficient exposure to the surgeon. The surgeon should be familiar so that the procedure is reproducible, and that the surgeon knows about the limits of each of these exposures, and the exposure should lead to an efficient procedure. And we'll talk about that in a little later. The technical aim of this operation is to replace the worn out articular cartilage with maintaining the hip center, hence hip replacement surgery. And this maintains ideal mechanical environment. Sometimes, however, we need to reconstruct the hip center, as these folks have done effectively. We need to ensure that our artificial joints is stable. Increasing the head-neck ratio increases stability. Well, we do also need to look out for impingement between our implants and between our implant and bone. And component positioning is important. We know about the ideal positioning or range for the acetabular component, but what we are learning is that our static positioning may be different from the functional cup positioning, particularly if the patient has any pelvic or spine disease. We must get our soft tissue tension right by restoring the offsets. Restoring the horizontal offset ensures ideal muscle tensions around the hip, because errors can manifest in instability, pain, or even limp. Restoring the vertical offset ensures no leg length discrepancy. But we also need to understand the relationship between these two offsets and how to ideally choose an implant or stem. The procedure needs to be efficient. The surgeon, there should be a clear plan before entering theater. We don't become clever just because the patient is asleep. And we should anticipate and have specific, identify specific problems and have clear backup plans for these. I assess, in my planning, I look at the patient and I look for the Trendelenburg either of hip origin or being caused by coming from somewhere else. I assess for abduction contracture, as this can affect stability. We then use X-rays for planning. The things I look out for are things like the protrusia, the location of any leg length discrepancy and have a plan of how to correct it, and variations in canal width as we can be caught out, and therefore have an effective plan for this as well. So templating is useful. I mean, this can be done directly on X-rays or using software. I understand there are imaging and magnification issues, but at least it records evidence of planning. Now that we've had a plan and we've executed it excellently, what do we do now? In my opinion, the most important thing is regular review of outcome. The registries provide us and the patient with information regularly, and we get to learn about forest and funnel plots. Length of stay gets people excited. This unit had a length of stay of between 2 and 4 days. They then instituted a patient-centered time-based program, which reduced the length of stay to 26 hours. So clearly there are margins of gains, but this is an exercise in health economics. In the UK, NICE provides us guidance of how to prevent thrombosis or mitigate against thrombosis, which avoids embarrassing situations of the family or the coroner. Infection should be below 1% for primary hip surgery. And of all the measures that we use, probably surveillance is the most important to ensure that there is no breach of our infection protocols. So what do I see in the near future? We're learning how to adapt our procedure for different pathologies, especially the pelvis and spine pathologies. And we're learning about the place for robots. But we need to remember that the cheapest, most versatile, and most efficient robot in theaters will still be the surgeon. Thank you.
Thank you so much, Professor Arshad Khalil from UK, for this marvelous presentation. Professor Arshad, you are live with us, sir. Okay, the talk of Professor Arshad was recorded. Now we will move to the next speaker. Our next speaker will be Dr. Ali Al-Moghazi, will speak about fast track rehabilitation after total hip replacement.
Hello, I'm going to talk about
Thank you, Mr. Chairman, for this invitation. I am Ali Al-Moghazi, specialist of rheumatology and rehabilitation. My topic today is about conventional versus fast-track rehabilitation after total hip replacement. This work was done in Germany. Hip replacement surgery is the most successful orthopedic operation worldwide. As Dr. Arshad said, it was chosen by WHO to be the operation of the century due to the enormous pain relief and remobilization it offers. The success of this operation is, however, depends on the quality of post-operative rehabilitation following it and patients' dedication and performance during it. Fast-track surgery has been introduced more than 20 years ago by Henrik Kjellet in Denmark for abdominal surgery. In the last decade, many Scandinavian countries started enhanced recovery after surgery programs to allow a short hospital stay and rapid ambulation of patients. The achieved socioeconomic gain have encouraged several health systems in Western Europe to follow this approach. In Germany, 260,000 hip replacement surgeries are done per year, with increasing tendency. Nowadays, several patients undergoing joint replacement are young and need to be rapidly integrated back into work life. Furthermore, with the aging population, healthcare systems may not afford a long hospital stay or offer complex rehabilitation. Therefore, the establishment of such a fast-track pathway would allow a strong socioeconomic improvement. However, a multidisciplinary approach has yet to be standardized to have success. In order to achieve this goal, 60 patients undergoing total hip replacement for hip arthritis undergoing either conventional 3 to 4 week rehabilitation program after a normal hospital stay, or an enhanced recovery program that starts at operation day with early discharge after 3 to 5 days and ambulatory rehabilitation of 2 to 3 weeks were compared. Both groups were matched for age, gender, body weight, and surgical indication. This study was prospective randomized controlled trial and was done in Center of Joint Replacement in Bruder Krankenhaus, St. Joseph Hospital, Germany. Study was approved by the local ethical committee and registered in the German clinical trial registry. There were 32 females and 28 males who ranged in age between 47 and 80 years. The mean body mass index was 28 in both groups, and the mean pre-operative WOMAC score was 65, and the mean pre-operative Harris hip score was 45. Our exclusion criteria was hemiarthroplasty or bipolar prosthesis, fractured neck femur, post-traumatic hip arthritis, elderly patients more than 80 years, massive obesity, early surgery-related complications, and incompliance. All cases were done under general anesthesia in a standard operation room with laminar flow. The approach used was minimally invasive posterior approach. All patients received pre-operative single-shot antibiotic prophylaxis and 1 gram of intravenous tranexamic acid to reduce bleeding. All acetabular cups were cementless. All inlays were made of high cross-linked polyethylene. Femoral shafts were either cementless or cemented. Local infertilation analgesia was given in all cases except with known allergy. No surgical drains were used and urinary catheters were avoided. The mean length of hospital stay in the conventional group was 7.8 days compared to 4.5 days in the fast track group. Complications included 1 hip dislocation in either group, and only one patient needed a blood transfusion in conventional group. There were 2 readmission in the conventional group because of cardiac problems compared to none in the fast track group. None of the patients in both groups had joint infection or developed post-operative deep venous thrombosis. As regards the functional outcome, the mean WOMAC score 6 weeks after total hip replacement was 26 in the conventional group and 23 in the fast track group. 12 weeks post-operatively, the WOMAC score averaged 16 in the conventional group and 10 in the fast track group. As for the Harris hip score, patients in the conventional group had mean score of 69 6 weeks and 82 12 weeks post-operative. In comparison to 79 and 91 in the fast track group respectively. The differences were statistically significant in favor of fast track group. Our conclusion was that fast track rehabilitation after total hip replacement is associated with early patients mobilization and reduced hospital stay and cost, with better functional outcome and without increasing the risk of complications or the readmission rate as compared to conventional group. Thank you very much.
Thank you so much, Dr. Alia, for this very nice presentation. Thank you so much. Unfortunately, we have to move to the next speaker because he's from UK and he has an outpatient clinic. So we will move to the next speaker, Dr. Ashwin Yonathan from St. Peter and Ashford Hospital, UK, and then we can take a break for 10 minutes. Our next speaker will be Professor Ashwin Yonathan from St. Peter Hospital, UK. Professor Ashwin will speak about hip revision in periprosthetic fractures. Professor Ashwin? Dr. Yonathan?
Can you hear me now?
Yeah, I can hear you, sir. Thank you so much for joining us.
Fine. Can you see my slides?
Yeah.
Yeah, okay. Thank you so much for inviting me back. Last time you invited me just before Christmas, a year has passed. And it's an honor and a privilege to be here. Thank you, sir. The topic which I am going to present is about hip revisions in periprosthetic fractures, and take you through some examples also. The hip periprosthetic fractures or revisions, the percentages are growing up because of increased age, because of osteoporosis, because of femoral deformities and uncemented stems. The uncemented stem, we are doing a big multi-central trial to look into that particular aspect. Now, I'm just going to start with what we have, our experience. So I work in a rather large DGH in Surrey, where the average life expectancy is about 88 for females and about 84 for males. So there's a preponderance of elderly population. So I looked at the data from 2011 to 2021. Mr. Khalil also works with us. He had done lots of work in finding this data. There were a total of 214 patients, so a big cohort of patients. The types of fractures we divided into periprosthetics around knee, interprosthetics, and periprosthetics around hip, of which surgical fixations and revision. So for this particular talk, though I will vary into knees also, but we'll focus on the periprosthetics around hips. So the periprosthetics around the hips, we divided again into surgical fixations and hip revision THRs. And you can see that the numbers of revision THR are more than the numbers of surgical fixation, or they're equal preponderance. And from a classification point of view, majority of the periprosthetics which we had was Vancouver B, followed on by Vancouver C. And the mean age of fixation, we divided this from 2011 to 2016 and from 2017 to 2021 to see if there was any age difference, or is the age population going up or down. We didn't find any particular age difference, but you can see roughly the ages we are talking about is about 80 plus or early 80s. Now, we also looked at the weight for surgery, because these are complex fractures, and hence it requires a particular subset of skills to do it. The normal average fixation time which we had in our unit was about between 3 and 4 days. We also looked at our complications. Now, I have been particularly harsh with our surgical complications. So any complications, so if you see, there's a subsector which shows there are complications from fractures. So if a cable was broken or there was small subsidence, I have taken that as a complications. But roughly, the interesting part is surgical site infection is you always have to consider in this subgroup of patients, as some of them are diabetic, some of them have got other immunocompromised disease, and they have got osteoporosis. Medical complication. Now, this is a very important topic that we need to look into. So as years have gone by, I've realized that the most important person who plays a role in this is the medical team, that's the care of elderly and the anesthetist. I have reached a stage where I rarely would take a patient if they don't have the first 24 hours in ITU, because it's the pneumonia that kills them, it's the UTI that kills them, and it's the DVT that kills them. We looked at the mortality figures. Mortality figures are lower than what the mortality figures are generally quoted. But you can see for femoral, proximal femoral fixation, the mortality is higher than the proximal femoral revisions. Obviously, the data can be slightly biased because you are doing revision surgeries in patients who have got lesser comorbidities, but not in our center. Yesterday, I did a patient a revision who is 98. I'm afraid what needs to be operated on by fixation, we fix it. What needs to be operated by revision, we revise it. And we rarely look into mobility except if they are ASA 4+. Having said that, this patient operated yesterday was ASA 4. And we also looked at the grades of ASAs. You can see the grades of ASAs is slowly creeping up as the years go by. Now, I'm going to go to some examples to give my pearl of wisdom from my experience. So, this is a lady who has had 2 revisions. So, had 1 primary and then had a revision. You can see some stud graft there. She's slightly demented, but she doesn't have any other comorbidities, i.e., she's ASA 2, and she goes out walk every day. And this is the fracture. This is the fracture pattern. Now it's important that this fracture pattern, the most important point one has to recognize is the abductor attachment or the trochanter. So under the picture of that, and I nowadays use a cable and a plate. I use the cable to hold the trochanter back. Though the X-ray might not look very pretty at the end, I would recommend you guys to consider that. Simply that I think, in my experience, it gives the abductors a better chance to hold on to. And this is the lady walking. If you could see, she is the right side I have done, not the left side. Okay, so she's walking 6 weeks post-op. Okay. In a similar pattern, if you look at this fracture, which is a very similar fracture pattern, previously it used to be done by cables and holding the cables. In my experience, holding the osteoporotic bone by cables probably is not a great idea. I have not seen, the questions I'm often asked is whether it affects the soft tissues and the cables are put in. I personally have not had lots of problems with that. Now, going on to a very similar fracture. So this patient has an uncemented chorale stem. She's otherwise fit and well. Though it looks like an indolent fracture, if you look into that, by the time you take out the stem, the trochanter would have gone into pieces, and then you're looking for stability here. This is my post-op X-ray. Whenever I can, I will take the both components out. I rarely do not take both components out because I think taking both components out gives you a better chance of stability, as I believe in the combined anti-version. Hence, it's important that I can control both sides. So my standard practice is take the cup out, put a dual mobility in, put a plate in, and a long uncemented stem. And this lady has done very well. You can see the post-op X-rays. Now, I'm slightly staggering onto a field which I was not asked to, but I just want to emphasize a couple of points here. So this is a gentleman. Who had a knee replacement some 10 years ago. He had some pain for 6 months, 8 months. He didn't go to his GP, and he just staggered around. And this is how he came one day walking into a clinic. The importance is here to act fast. Once we have seen this, this gentleman is not in a lot of discomfort. He says his knee is unstable, but he does not say he is in pain. When I opened up, it was absolute carnage there, as most of you would know. So it is important to to get hold of these patients at a faster rate, even though they are less symptomatic. In this particular patient, I had to do a hinged knee. I like not to do a hinged knee whenever possible, but I'm afraid when everything, the soft tissues are gone, this is the only, he's 78, he's doing well, but it is a hinged knee. Similar pattern, an 83-year-old male, he has been for 2 years. And you can see his wife died. He didn't want to come into hospital. Then COVID happened. He has got a number of comorbidities. But you can see the CT scan shows that there is a lot of destruction in the bone. When I opened up, this is the proximal femur, and there is nothing left there. So this is what we did, and this gentleman. It's walking. The importance of why I wanted to show this is that the other side is still not done. So he's not that very symptomatic, but you can understand that he will get symptomatic very soon. This is his 6 weeks post-op range of movements. Now, I want to show some examples of some cases. Obviously, any surgeon won't show his own complications. So this was what case is done by one of my predecessors. A fracture similar to this pattern. It was decided to fix it. I don't exactly know what the comorbidities of the patient is. You all know what is going to come next. It is a too rigid fixation. The fixation fails. It gets infected, the metalworks is taken out, and then the patient had to have a revision surgery. The whole process had taken about 1.5 years of patient's life. So this was a recent referral to me for a fractured nail. And this nail has broken twice. Within 18 months, the nail has broken twice. And I think so they went back again and did the nail, but there's one more picture to show the nail has broken again, which I've not pushed on the system. She's otherwise written well, 17 months apart. And I went in and did my standard practice is to put a dual mobility and a couple of screws and a long stem. Now the importance is the trochanter was okay, so I didn't put a plate there, the nail which was there was 12 millimeters, which I changed into 16 millimeter stem. This is another fracture which I'm sure you know what I'm going to show. It's too rigid fix. Well, the fixation, you can see a stem is there. These are difficult fractures to treat. It broke. We had to do a long femur. I had to take everything out. Okay, and this is a similar pattern where there is a distal femur, where there's a knee revision done, there's a fracture above it, there's a cement mantle, it is a stiff construct, and behold, it breaks and had to go for a distal femur replacement. Now, this patient is mine, and I've learned from my mistakes. So this is a 78-year-old lady who is very obese, and I did this hoping that it'd be fine. She's an ASA3 patient. She lingered on, and had the plate broken off, and then I had to go and do a distal femur, this is her. After that, a couple of months later, and this is a very recent fracture which I had. So this looks as if you can fix it. Okay, it's quite important to detailed study the fracture pattern from a CT and the bone point of view. So I did not think I could fix it. And she has got a hip replacement above it. This is a classical case. Okay, she's slightly obese. So when I took it, I didn't have the confidence to fix it. So I wanted to do a distal femur. I opened up. This is it. There is nothing. There is no much amount of bone left to fix these fractures until you do a dual plating on the medial side also. But in this particular patient, I didn't think doing a dual plating would have made a difference. We had this done. Thank you very much for giving me the opportunity to present. I'm sorry if I have done a little bit of knees also, but I just wanted to show my experience.
Thank you so much, Professor Ashwin Yonathan from St. Peter Hospital. Thank you so much, sir.